All right. Welcome to another Six Patterns video. My name is Max.
I'm Kevin.
And today we're going to look at a case, and we're going to use the poster actually quite a bit today, just to show people how it's actually used in practice.
It's kind of a dynamic session.
It'll be a dynamic session, like most of them, hopefully. This case is from a 62-year-old female.
Okay.
And she presents with shortness of breath and cough, and she has imaging studies that actually show quite a bit of reticulation, lower lobe bilateral reticulation. Not a lot of honeycombing radiographically.
So the clinical diagnosis coming into this is rule out IPF, idiopathic pulmonary fibrosis, lower lobe reticulation with or without honeycombing. Today we'll bring up that high in the differential. And because it's such a bad diagnosis, if they can't make the diagnosis by other means, they're going to take the patient for a surgical biopsy.
Exactly. And unless the patient, nowadays if the patient has classic IPF radiographically and clinically, they won't even go to biopsy.
Right.
But this patient, we know that there was some abnormality, either what the radiograph showed or the clinical presentation, and the fact that she's a woman might have been it.
Right.
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 So here's a wedge biopsy. This is from the lower lobe. And as far as our 6 basic patterns, Kevin, what are you thinking from this low power?
Well, this biopsy is a mess, obviously. There's way too much solid stuff here. This should all be a beautiful, wispy alveolar parenchyma with a little bit of pleura. And here
It really
we have,
should all look kind of like this.
Exactly. And now we have just too much consolidation by this pink material with scattered islands of blue. So I think with this much distortion of the surface, you'll notice at the top of the screen that the pleura is kind of pulled up and down and has thick and thin areas under it. This, to me, is a classic fibrosis pattern.
Okay. So you think, just looking from low power, before we look at any high power images, that we're dealing with a fibrosis pattern.
Right.
So if we were to go to the actual poster, and we wanted to look at the poster and decide which main pattern we're in, we'd probably go to 2.
Correct.
Fibrosis pattern. And then we can look at the fibrosis pattern and look underneath the image of the fibrosis pattern and see what else it is that we should be looking for in this case.
Right. And if we start that off from the first 15 seconds of looking at the biopsy, and we've looked at the possibilities under the image, we're already way ahead of the game. We're close. We're probably 90% of the way to the diagnosis.
Exactly. So fibrosis with variable involvement, fibrosis with honeycombing only, fibrosis with more of a diffuse alveolar wall fibrosis, with pleuritis, with granulomas, or airway-centered fibrosis.
Right. These are the main considerations. So if we've at least read those possibilities, once we've decided it's a fibrosis problem, we're way ahead. So let's take it from there. This looks like a fibrosis problem. Let's ask the questions. Is it variable? So we have to look at our case and figure out, do we think this fibrosis, this pink consolidation, is it uniform throughout the biopsy, or are there areas where the alveolar parenchyma looks normal?
Well, now, I think just from this image, I think it's pretty clear to say that this is a highly variable process.
Right.
We have areas that are completely spared, and we have areas like this that would probably meet most people's criteria for microscopic honeycomb remodeling.
Right.
Advanced fibrosis, architectural distortion, cystically dilated spaces filled with mucin debris, and I would hazard to guess that those are lined by ciliated respiratory epithelium there.
Yeah, that's an interesting point. So let's go back to the poster for a second and look at that differential diagnosis for variable fibrosis.
Okay. Fibrosis with variable involvement, usual interstitial pneumonia of idiopathic pulmonary fibrosis, asbestosis, rheumatoid arthritis, and other connective tissue diseases, but rheumatoid arthritis is the one that most commonly shows this pattern of variable involvement, chronic hypersensitivity pneumonitis, and pulmonary Langerhans cell histiocytosis.
So the clinicians have said rule out IPF, and we've arrived at the top diagnosis in this category is usual interstitial pneumonia, or IPF, clinically. So I guess my question would be, if I get to this place, isn't it just totally reasonable for me to diagnose UIP?
Well, you've certainly landed at what I think old school pathology mantra would say is a UIP diagnosis, right? We've got it marked fibrosis, architectural distortion, and areas of perfectly normal appearing lungs. So we've got that geographic heterogeneity that everybody thinks about for a UIP diagnosis.
The patchwork.
The patchwork fibrosis. But we all know, and our clinicians know, that there is a differential diagnosis with regard to etiologies of what can give you a UIP pattern fibrosis. And in fact, the differential is listed right here underneath the variable involvement, right? We think about IPF, we think about pneumoconioses, we think about connective tissue disease, we think about chronic hypersensitivity pneumonitis. So then the question becomes, we have a general UIP pattern. What are the features that we want to look for in the setting of a general UIP pattern that might help us make a decision as far as which one of those 4 or 5 possibilities this is?
And I would say that this differential diagnosis has, other than UIP of IPF, all the other elements in the differential diagnosis have things associated with them that we should be looking for to point us in that direction and away from IPF. So it isn't that the UIP has something specific that's going to help us.
Right.
The UIP of IPF, it's that the other elements in the differential diagnosis have things we can look for.
They have findings.
Exactly.
So you should think about making a diagnosis of UIP, which you think might be of IPF, as more of an exclusionary diagnosis. Like you've got a UIP pattern and you don't find any of these other histologic features, then maybe you are dealing with a UIP of IPF.
Brilliant.
So asbestosis pneumoconiosis, we'd look for ferruginous bodies, we'd look for dust. Rheumatoid arthritis, we look for lymphoid infiltrates, germinal centers, bronchiolitis,
maybe
pleuritis,
yeah.
chronic hypersensitivity pneumonitis, lymphoplasmacytic cellular interstitial infiltrates of the interstitium, poorly formed granulomas.
And all of the airways being pretty abnormal in chronic hypersensitivity pneumonitis, whereas in UIP of IPF, the airways may be mostly normal.
Exactly. So with that in mind, let's go back to our case and see if we can find anything that might help us with this differential diagnosis.
Great.
So here we are back at the case. We've got a nice wedge biopsy, and we can look a little bit more closely at some of these areas at higher power and start to get the sense that, this isn't one of those clean UIP of IPF type biopsies.
Mainly pink, right?
Yeah, it's not a mainly pink biopsy. In fact, if we look at this view right here, I think most of us would probably say, well, that looks like a cellular interstitial pneumonia, maybe a cellular NSIP almost.
Superimposed on or with fibrosis,
right,
yeah.
For this pattern of injury. So we've got brisk lymphoplasmacytic infiltrates. You can see wall-to-wall plasma cells here.
And that looks like a fibroblast focus right there. Is that possible?
While we're here, we can comment on this fibroblast focus, right? Yeah, sure. So fibroblast foci are part of the temporal heterogeneity that you see in the UIP pattern, and we would expect to see fibroblast foci in all of those different etiologies that we're considering in the differential diagnosis. So the presence of this fibroblast focus actually doesn't help me at this point because we're still trying to decide what of these 4 possibilities this might be.
In fact, it might lead you to a premature hypothesis, meaning you might put all of your money on that fibroblast focus, only to find out later that the patient actually has rheumatoid arthritis clinically, and they forgot to tell you.
That never happens. Okay, so what else do we have in this in this biopsy? Now, what's this?
That's a secondary follicle. That is a lymphoid follicle, and that's a distinctive finding in the lung. It may not be abnormal in the lymph node, but in the lung, the presence of secondary follicles like that is distinctly abnormal.
Right, and points you away really from a diagnosis of
IPF.
Idiopathic pulmonary fibrosis, because secondary follicles really kind of are screaming out, hey, this might be a connective tissue disease associated interstitial lung disease, and rheumatoid arthritis is the best at forming secondary follicles in the lung.
And some conditions like chronic hypersensitivity pneumonitis don't seem to make secondary follicles as a part of their process unless there's some other problem superimposed.
Despite what's in the literature sometimes.
Right. We can't account for what's in the literature always unless we write it.
That's true. So not a lot of pleuritis here, but there is some fibrotic thickening of the pleura, suggesting that there's been some chronic irritation over time to the pleura.
And if you have a question, you can do a reticulin stain right there, and you'll see that the elastic tissue and fibrous component of the pleura is actually expanded. Whereas in IPF, if you do an elastic tissue stain or reticulin stain, you'll see that there's this distinct preservation of the pleura. The pleura doesn't seem to be involved.
Should be very nice and thin and delicate.
Yeah.
So in this case, so far, we've identified lymphoplasmacytic cellular interstitial infiltrates, almost looking a little NSIP-like in some areas. We've identified secondary follicles.
Right.
There's a little bit of chronic bronchiolitis. And all of that is superimposed on what is a basic UIP pattern of fibrosis.
Right. So is this helpful? If we establish in our diagnosis that this is most likely related to an autoimmune disorder, systemic autoimmune disorder, and rheumatoid arthritis would lead our differential, if the clinician says, well, I was hoping we'd get an IPF diagnosis because we have a therapy for that.
The antifibrotics.
Yeah. Approved by the FDA.
But we don't know if the antifibrotics work in this disease condition right now.
But if they work in IPF, which is another question, whether they work in IPF.
Whether they actually work, yes.
Correct. They certainly don't reverse the disease, but are we going to approach this with an antifibrotic, or are we going to use something else? And I think if we say that we think this is autoimmune, regardless of whether the patient has RA, maybe they just have an elevated ANA, maybe their C-reactive protein is elevated, or their SED rate, approaching this patient with a different therapy might be the best.
Oh, absolutely. I mean, if this is my lung biopsy or my wife's lung biopsy, I'd want to see some immune suppression, some immune modulation, because we can see all those plasma cells. We can see all the lymphocytes. They're the ones that are mediating this injury. And an antifibrotic isn't going to do anything for that.
Right.
So this is a case of a general UIP pattern fibrosis in a patient with rheumatoid arthritis. This is not usual interstitial pneumonia of idiopathic pulmonary fibrosis.
Great.
So don't forget to comment below. If you have any questions or disagree, let us know and we'll respond to you. And hope you enjoyed.